Hello guys, welcome to the subject-wise test series 2021 ophthalmology, and we will be discussing all the questions of the ophthalmology. So let's get started. Your question number 1. So question number 1 says that this is a 21-year-old man who is coming to the emergency department due to the double vision on looking towards the right, looking towards the left. So this is an important thing because this will help you in finding out that what may be the problem. There is a diplopia and which side is affected. That will help you because they are having the diplopia towards the left, right? Now there is no past medical history. Examination pe BP is normal, pulse is normal, regular hai. Now upon examination of the ocular movements, patient is unable to abduct his left eye. So when a patient is unable to abduct his left eye, we can think about the left lateral rectus, and there could be a left lateral rectus palsy. So from this I can make out, and the person is also having the diplopia towards the left, so both are actually sinking, right? Now diplopia with the horizontal separation of the images is coming when attempting to see towards the left. Now whenever we have got a palsy in the horizontal direction, we have got a horizontal muscle affected, we will have two images which are horizontally separated. When we have got vertical diplopia, they are vertically separated. Now here they are saying that there is a horizontal separation of images. So this again tells me that this is actually horizontal diplopia. See, my aim is not to just tell the answer of these questions. My aim is so that you can understand why we get this answer, and if you get a similar kind of question, maybe not exactly the same, you know how to approach it. So horizontal separation of images, and it is worse when looking at a distance. So when the person is trying towards the left side, which is the paralyzed side, diplopia is increasing. And I think we all know that a very common thing, that is that diplopia increases or diplopia is maximum. When it is maximum, when the patient tries to look in the direction of the action of paralyzed muscle. In the direction of action of the paralyzed muscle. That means when the patient tries to look towards the left side and the left lateral rectus palsy is there should be increase in the diplopia. So they are telling the same, right? Now another thing is when they are covering the left eye. So that is actually covering the paralyzed side. So when they are covering the paralyzed eye, the outer image is disappearing also. That means there was a false image which was coming due to the paralysis on the left hand side, and when the patient is covering it, we do not have that image. So again it confirms that there is a paralysis of the left eye. Weakness of which of the following muscles is most likely responsible for his symptoms? Left lateral rectus, left medial rectus, left superior oblique, and the right lateral rectus. Now first of all, it cannot be a left superior oblique because this will cause a vertical diplopia. This will cause a vertical diplopia, and the question is giving you the horizontal separation of images. So we are having the horizontal diplopia in the question, right? So it cannot be this. Then another important thing is that the double vision is occurring when the patient is trying to look towards the left. So it is not the right lateral rectus. So we are having some problem on the left side. Left lateral rectus or the left medial rectus, patient is unable to abduct his eye, so it is not the medial rectus, and see, the answer to the question is the left lateral rectus. So I think everything is very clear. Whatever information has been given in the question, we have used it, how to utilize it, how to comprehend it, and move towards your final diagnosis. See, this is a evaluation of diplopia called as diplopia charting. Based on this, the information is also given in your question. It is indicated in the patients who are having the confusion or having the double vision. Patient will wear the diplopia glasses, red on the right side, green on the left hand side, and this is by convention. Like we can have the opposite also, but by convention R for R we take red in front of the right eye most commonly, and the room has to be a semi dark room, and the light is shown from a distance of the 4 feet, and the patient has to comment on the position of these images in all the 9 gazes. What are 9 gazes? These are the positions of gaze. So when the patient is seeing straight ahead, straight up, straight down, do you remember the gazes? So this was your primary gaze, then straight up, straight down, straight right, straight left, and then the combination, that is your dextro elevation, dextro depression, levo elevation and levo depression. So patient has to tell that when he or she is looking in these particular directions, what is the direction of the or the separation of images that is taking place. So patient will tell you, see this. So can you see in a particular direction he is seeing only one of the image, so there is a suppression, then there could be both the images, there can be horizontal separation, there could be vertical separation. Depending upon that we will come to know that which muscle and which eye is affected. So this was your question number 1. Alright. Now coming to the question number 2. Here we have a patient with the features of proliferative retinopathy in one eye, background diabetic retinopathy in the other, and which one of the following is most likely to provide an explanation. Now this is a catch actually. Seeing the question, it looks that as if this question is on the diabetic retinopathy, but actually it is not. The trick to the question is that here the patient is actually having the asymmetrical diabetic retinopathy. So patient is having asymmetrical diabetic retinopathy because in one eye we have PDR and the other eye is having background diabetic retinopathy. Now first of all let me tell you what is this background diabetic retinopathy. This is something which takes place even before the non-proliferative diabetic retinopathy. We all know that there are 4 stages of diabetic retinopathy. First we have NPDR, then we have the PDR, right? Then even we have the maculopathy, and finally we have the advanced diabetic eye disease, right? Now even before this NPDR we can have the background diabetic retinopathy. So this patient is having asymmetrical diabetic retinopathy, and this asymmetrical diabetic retinopathy is very much suggestive of the ocular ischemic syndrome. This is called as the ocular ischemic syndrome, right? So what do you mean by ocular ischemic syndrome? That means we have a lot of ischemia in the eye, and this ocular ischemic syndrome actually takes place when there is more than 90% stenosis, in the carotid artery, and there are many presentations of this stenosis of carotid artery. This is the main blood supply of the eye. So if I am having the ischemia in the eye, these patients can present basically as the stroke. Many a times these patients are presenting with the stroke. Then we have the TIA, transient ischemic attacks are there. The patient will be presenting with the amaurosis fugax. The patient will be presenting with the transient obscuration of vision. Patient can also be presenting with the CRAOs, that is central retinal arteriolar occlusion. Patient can also be presenting with the anterior ischemic optic neuropathy. So there are so many ways, because you have ischemia not only in the posterior segment, also in anterior segment. So slowly and gradually this patient will also go towards the anterior segment ischemia. So many of the things which actually represents the signs of the anterior segment ischemia will also be evident. So on that lines you have to think what is the information that you are is going to give you the idea about the ocular ischemic syndrome. So let's see the chest X-ray. No. ECG. Now ECG will tell you about the rhythmia or the rhythms. So this is not actually what we require for the ocular ischemic syndrome. Coagulation screen, no. ECG, no. So yes, obviously the best one is your carotid Doppler ultrasound. The other one that can help us is your fluorescein angiography, because the patient is having diabetic retinopathy. So diabetic retinopathy can best be evaluated with the help of fluorescein angiography, but fortunately they have not given this to you in the question, so you are not confused about it. So wholeheartedly you can go with the this one, carotid Doppler ultrasound. Now because many questions are being asked over this ocular ischemic syndrome, and it's an integrated topic in a way, because the pathology, the pharma, medicine, ophthalmology, and all these things are actually involved in it. So I would like to give you some extra information about it. So let's see what happens actually in ocular ischemic syndrome. So number one is that we have a ischemic pain, because the patient is having acute hypoxia, we are having the ischemia, so patient is in great pain, and as you see, most common cause of ischemia is actually the hypoperfusion of the carotid artery. So we are thinking in terms of the carotid artery hypoperfusion. We are thinking about the carotid artery hypoperfusion, right? So we can have a isolated ocular ischemic syndrome, or we can have it as a part of the syndrome in the body. So this is a very rare condition, and it is occurring secondary to carotid artery stenosis. 80% of the time it's unilateral. Now again in the question, when you have to decide that which syndrome it is, there also it plays a role, that whether it's a unilateral, bilateral, acute hai, chronic hai. So all these things play into it. So most of the times it is actually unilateral, right? So what is the pathogenesis? More than 90% of the carotid artery is not able to work. There is most commonly atherosclerosis. So another important thing that you need to know related to it is the atherosclerosis, and many a times they will also give you the risk factors, which are diabetes, hypertension, ischemic heart diseases, and cerebrovascular diseases. Like in diabetes is given in our question. Cerebrovascular disease, I told you, it can be a question of the stroke also. So you should have all these things in mind, that if my question contains diabetes, hypertension, ischemic heart diseases, it could be acute MI. If they are giving you any history of MI or there is a stroke, you have to think about this. So basically all these conditions, diabetes, hypertension, atherosclerosis, all these conditions are more common in males 60 to 90 years, smoking, carotid hypertension, diabetes, hyperlipidemia. So again look for these risk factors in the question. All these things are more common in elderly age, male, as well as smoking, diabetes and hypertension. And as I told you that the manifestations could be manifold. This patient can be presenting as the transient ischemic attacks. The patient will have transient obscuration of vision, amaurosis fugax could be there. It could be central retinal arteriolar occlusion, because we know CRAO ka most common cause is thromboembolism. So that could be a embolus, and we can also have the stroke, or a very important thing that is given in our question, asymmetrical diabetic retinopathy. So see, asymmetrical diabetic retinopathy, whenever you are having in the question, please do think about ocular ischemic syndrome. Now look at the symptoms. Symptoms may obviously because you know main blood supply is affected, so loss of vision has to be there, and it is actually progressive one. Then we have transient blackouts, amaurosis fugax बहुत common है, and pain. Now pain is not present in every person, but much frequently we have the episodes of pain, and some of them will also give you the delayed dark adaptation. Alright, now look at the signs. Signs may we have got the signs of anterior segment ischemia also, like we have the edema in the cornea, anterior chamber may flare could be there, pupil may dilated and poorly reacting, rubeosis iridis, because whenever you have got ischemia, you will always have the neovascularization also there. If I have the ischemia, I will also have the neovascularization. So all these signs would be there. Then because you know we can have due to this neovascularization, due to the ischemia, we can also have a cataract. So we can have a cataract, we can have the neovascular glaucoma. So anterior segment signs भी हो सकते हैं, starting from corneal edema, starting from aqueous flare, rubeosis iridis, cataract and neovascular glaucoma. Think about this. Alright, now look at the appearance. So we have the appearance of total inflammation, we have episcleral injection also, corneal edema also, we have aqueous flare, we have rubeosis iridis, and we have cataract and glaucoma that we have already discussed. Fundus examination, now this is again more important because many a times they are asking you about this. So a very important thing is venous dilatation with irregular caliber, right? But an important thing is with low or mild tortuosity. This is a very common thing, or we can say a common difference from the CRVO, because many of its changes are very similar to CRVO, but CRVO may there is occlusion in the veins that will always give you more and more tortuosity in the veins. Here you will not have a very little tortuosity or even no tortuosity will be there. Retinal arterial narrowing can be there. Then we can have dot and blot hemorrhages, microaneurysms in the cotton wool spots. So I told you that this can present as a diabetic retinopathy, especially the asymmetrical diabetic retinopathy. So we can have microaneurysms also, cotton wool spots also, dot and blot hemorrhages also, neovascularization, NVD, NVE can be there, even the macular edema can be there. So all the things which are related to diabetic retinopathy can be there. Then coming to the FFA. Now early phase will show you delayed choroidal filling and also the prolonged transit time that is there, because we have ischemia, so obviously there will be delaying in the filling, and then you can also see the hyperfluorescence and leakage because of the lot of neovascularization. So all these things you already know because we have CRO and we have asymmetrical diabetic retinopathy. These are your pictures showing the fluorescein angiography, and what are the things that you can see here. In the fluorescein angiography, you can see there is actually the dilatation of the veins. Can you see? We have got, is this visible here? Is this color visible, or I'll use the other one? So we have the venous, I think now it should be visible. We have the venous dilatation is there, arterial narrowing is there, due to which we have got the hyperfluorescence. You can see this hyperfluorescence, right? Then coming to the carotid imaging. So what are the things? So it was this thing that has been asked in your question. So we can do the color Doppler ultrasonography, we can do the digital subtraction angiography, we can also do the MR angiography. So out of these, because you know it's basically all about the vessels, because there is a carotid stenosis, so anything which is related to angiography will be the investigation of choice, right? Coming to the management, so the management depends upon the type of problem. If the patient is having a problem of anterior segment, we have to give the topical steroids and mydriatics. If there is a neovascular glaucoma, you have to treat accordingly. If there is a PDR, you have to treat accordingly. And if there is a macular edema, then intravitreal treatment with the intravitreal steroids or the VEGF agents have to be given. So whatever is the problem, according to that you have to give the treatment, alright. Now the differential diagnosis, very important thing. What are the things that you can keep in mind? Like you can ask me that, ma'am, this question was having asymmetrical diabetic retinopathy. Can I think something else, or should I only think about ocular ischemic syndrome? No, you can think of something else. Like one thing is, you can think about the diabetic retinopathy itself. They are clearly saying that the patient is having PDR in one eye and the background diabetic retinopathy in other eye. So what are the similarities? Because we were having the microaneurysms, we were having dot and blot hemorrhages, venous dilatation, cotton wool spots, all these things are there, right? But what is the difference? What the difference is that if I am having a diabetic retinopathy, it is usually bilateral and we will have characteristic hard exudates. Circinate retinopathy, that is very typical of diabetic retinopathy. So by that you can differentiate. Then you can think about the hypertension retinopathy also. Hypertension retinopathy may be cotton wool spots, hemorrhages, arterial narrowing hai. But again, if I am having a hypertension retinopathy, then I will have bilateral changes, and more important is no marked venous changes, the neovascularization. You will never get neovascularization in cases of hypertension retinopathy, that is for sure. And above all, we can also think about the non-ischemic CRVO. Non-ischemic CRVO have a very similar changes, similar to the ocular ischemic syndrome, but always remember veins are more tortuous, hemorrhages are more, and you have the typical splashed tomato appearance that you are not going to get in ocular ischemic syndrome. So a very, very important topic covering so many things. DDs are again important and the fundus images too. Alright. Now coming to the question number 3, we have a 35 years male who is coming with sudden blurring of vision in both the eyes. Similar episodes 4 months back also. He has been ringing sensation in the ears. Findings are shown below. What is your diagnosis? So first of all, let us try to see what are the findings which are given in this question. You have the sudden diminution of vision. So you are thinking of some acute thing. Then we have some syndrome because there is similar episode 4 months back also. Then we have got tinnitus because ringing sensation is there. Findings are also given below. So you can see this one. This is your vitiligo. We have hypopigmented patches. So these are your cutaneous things that we are having. Cutaneous involvement. We also have the eye involvement. Right, and then you can also see this one is your snow banking. So we are also having the snow banking. You can see the exudation in the vitreous cavity. We have snowball opacities, we have snow banking. That is giving you the pars planitis. This is giving you pars planitis. So do you know any case where you have actually uveitis? Any syndrome of uveitis? It is a syndrome of the uveitis. Uveitis is also presenting with the acute painful diminution of vision where you have cutaneous involvement. Yes, so that is your VKH syndrome. This is your VKH syndrome which is called as the Vogt-Koyanagi-Harada syndrome. Right, Vogt-Koyanagi-Harada syndrome or Harada disease also it is called as. Now you know what is the meaning of a syndrome. Syndrome means multi-organ involvement. So here we have CONE. This is your mnemonic. Mnemonic is cone. The mnemonic is cone. So we have got 4 organs involvement. We have got cutaneous skin diseases are there. Then we have ocular. Then we have got the neurological and then we have otological. All these 4 organs are involved in the Vogt-Koyanagi-Harada syndrome. Cutaneous may I can have vitiligo, I can have the hypopigmentation or it could be hyperpigmentation also. It could be hypopigmentation or it could be hyperpigmentation. In ocular I can have uveitis. Now what is the kind of uveitis? Here we were having both the eyes involvement. So here also we have bilateral granulomatous uveitis and that too the age group is young adults. It is the young age group that is most commonly involved. What are the things that I can get in CNS? So CNS may you can get the properties of meningism. Right, then we can also have the encephalopathies, neuropathies, all these things could be there in cases of the neurological. Then ear may we can have the sensorineural hearing loss, that could be there. Tinnitus could be there, which is given in the question. So all these things are there. And what is the HLA typing? It is the DHLA, DR3 and DW15. So all these things are very, very important because it is an inflammatory disease. That is why the bilateral exudative retinal detachment is also very, very common. Vogt-Koyanagi-Harada syndrome is also known for causing the exudative retinal detachment. Now there are certain other things that are worth noting like this. This is called as the Segura sign. What is Segura sign? That you can see over the cornea. This is actually the depigmented lesions. You can get the depigmented limbal lesions. You can get the depigmented limbal lesions over the cornea. This is called as the Segura sign. And then we can also get the sunset glow fundus. What is the meaning of sunset glow? the glow that you are getting is more. Why we are getting this glow? This is actually due to the RPE atrophy, because there is a atrophy of the retinal pigment epithelium. That is why we are getting more and more glow in the fundus. This is called as sunset glow in the fundus. So if you look at the options, is it a Behçet syndrome? No. What are the things that you are expecting to find in the Behçet syndrome? So Behçet syndrome mein, it is HLA-B5 positive, and basically you get the oral ulcers plus the genital ulcers. It is known for its ulceration. So if you are getting ulcers in the question, think about the Behçet's disease, and B for Behçet's and B for bilateral. This is also the bilateral condition, and along with this, a very important thing is that you get the recurrent mobile hypopyon. This is a very important thing, and many a times a question has come over the Behçet syndrome asking about the transient hypopyons. They are recurrent, but they are transient hypopyons. Then we have Vogt-Koyanagi-Harada syndrome, which can be the answer because it is having all the 4 involvements. Fuchs heterochromic iridocyclitis. Now what about this? Fuchs heterochromic iridocyclitis, this is a unilateral condition where you have heterochromia. So one side eye is affected. Unilaterally we have iris atrophy. Due to the atrophic patches, we have got the lighter color iris, lighter colored iris. So we will have unilateral attacks of the uveitis where you have the iris atrophy, you have got lighter color iris, and then a very important is the stellate, grey colored KPs will be present here. No cutaneous involvement is there. Middle aged may it's common, and then we have got the posterior synecdoche always absent. Posterior synecdoche always absent. These are the things which will help you in making the diagnosis of Fuchs heterochromic iridocyclitis or the Fuchs uveitis syndrome. Whenever you have attacks of uveitis with the glaucoma, with the heterochromia, with the iris atrophy, with posterior synecdoche absent. Then another thing is Eales disease. Now Eales disease is a most common cause of vitreous hemorrhage. So whenever we have the cases of vitreous hemorrhage, especially if it is a recurrent vitreous hemorrhage, if it is a recurrent vitreous hemorrhage and that too in the young patient, then you have to think about the Eales disease. Why do we have this Eales disease? It is due to the hypersensitivity reaction. It is due to the hypersensitivity reaction to the tubercular proteins. Whenever we have the hypersensitivity reaction to the tubercular proteins, we call it as the Eales disease. So here I am having sudden onset of blurring of vision. Now that can happen in vitreous hemorrhage, but we are having the similar episodes 4 months back. We are also having the ringing sensation, that is your tinnitus. So we are not going to have the tinnitus in the Eales disease, and we are not going to have the vitiligo also. We are not going to have the pars planitis. Therefore the answer to this question is Vogt-Koyanagi-Harada syndrome, right? Next question is your 10-year-old male who is brought to the OPD for impaired vision and redness in both the eyes. So it's bilateral and it's 2 weeks. So you can say that it is acute and it is bilateral. We have diminution of vision. Then we have got things like corneal opacity, Salmon Patch appearance on the cornea. There is devascularization. We also have vestibular hearing loss. Malformed teeth is also there. I think the diagnosis is very clear. This is a very typical case where I am having so many things. We have acute bilateral diminution of vision and we have corneal opacity, Salmon Patch. Can you tell me where the Salmon Patch is popularly found? So here the Salmon Patch is actually found in cases of syphilis. And we can have 2 kinds of syphilis. We can have congenital syphilis also and we can have acquired syphilis also. But congenital syphilis is mostly bilateral, acquired is usually unilateral. So we are not thinking about the acquired syphilis. Moreover, if you look at the age group, congenital is more common between 5 to 15 years of age. So look at the age of this child is 10 years. So basically I am thinking about this Congenital syphilis which the patient is having, along with the bilateral involvement, age group between 5 to 15 years, and we are having a Salmon Patch. Now usually we get a very typical triad in these children. What is that typical triad? This triad is actually called as the Hutchison Triad. This triad is actually called as the Hutchison Triad. And in this Hutchison Triad, you get obviously three things. What are these three things? So, one is the sensorineural hearing loss, vestibular deafness is there, that is given in the question. Number two, we have got the interstitial keratitis. Interstitial keratitis can lead to corneal opacity. Now, I will also tell you what is interstitial keratitis, and the third thing is the Hutchison teeth. We also get the Hutchison teeth. Hutchison teeth is your malformed teeth. They are called as the peg shape teeth, or the notched ones. Can you see this notching is there? This notching that you are, this notching that you are seeing in this teeth, this one is called as the Hutchison teeth or the pegging. Is it visible, guys? Is it visible, this one? So, this one is called as the peg-shaped teeth. Now, what is actually the Salmon's patch? Salmon patch they are talking about. So, the Salmon patch is actually found over the cornea. The Salmon patch that they are talking about in the syphilis is found over the cornea. And what is there? When we have got the congenital syphilis, we have got the devascularization. But though we have vascularization, we have infiltration, this is covered with the corneal opacity. So, that actually gives us the characteristic Salmon patch appearance over the cornea. Otherwise, we can have the Salmon patch at other places also. This is a pinkish patch that you are getting, that is your Salmon patch. So, we have that typical, corneal opacity is there. If you look here, we have number one corneal opacity, we have got the Salmon patch, right? Then we have got the peg-shaped teeth and vestibular hearing loss. So, total triad is found here. Bilateral means it is a congenital syphilis, so that is also there. So, the most probable answer to this question, what are the options they have given? Neisseria gonorrhoeae, Treponema pallidum, Mycobacterium tuberculosis or herpes zoster. So, it is Treponema pallidum because this is a very typical case of congenital syphilis. Now, I'll try to rule out the other options also. Number one is Neisseria gonorrhoeae. Now, Neisseria gonorrhoeae, if we are talking about the Neisseria gonorrhoeae, this is basically responsible for the acute purulent. This is basically responsible for the acute purulent kind of conjunctivitis, and because it is one of the bacteria that can invade the intact epithelium, it can also invade the intact epithelium. So, we can also have the corneal involvement. Here. So, we are not having any purulent discharge or any other thing here. Talking about the Mycobacterium tuberculosis. Now, first of all, if I discuss the causes of interstitial keratitis, can it be a Mycobacterium tuberculosis? See, what is interstitial keratitis? Interstitial keratitis means that there is a involvement of the deeper layers of the cornea, without the primary involvement. If there is no primary involvement of the epithelium or the endothelium, involvement of deeper layers of the cornea without the primary involvement of epithelium and endothelium. So, we have many causes of this interstitial keratitis. It could be congenital syphilis, and it could also be acquired syphilis, right? Then we can have the Cogan syndrome. It could be a Cogan syndrome where you get the vertigo, tinnitus, and deafness is there. Then we can also have the tuberculosis, we can have the trypanosomiasis could be there, we can have the what you called as malaria. It could be malaria, it could be leprosy. These are the things that are the common features. Now, yes, it could be due to the tuberculosis also. But in this case, we are not considering the tuberculosis. The reason is that tuberculosis is mostly unilateral, while here I am having the bilateral involvement, and that too it is mostly involving the inferior cornea. Then you are having the typical triad also, which we are not expecting in tuberculosis. Then next is your herpes zoster virus. So herpes zoster virus is not leading, it is not a cause of this interstitial keratitis. Rather, if I talk about the herpes zoster, this leads to the typical herpes zoster ophthalmicus, and we all know that this is a separate entity, herpes zoster ophthalmicus, and this is going to cause what you called as acute follicular conjunctivitis. This is causing acute follicular conjunctivitis. Then if you think about the corneal involvement, we can have the pseudo-dendritic pattern, right? It is not the true dendritic, it is pseudo-dendritic ulcers we can have. Then we can have the nummular keratitis, the coin shaped areas. This is the typical one. The nummular keratitis is the hallmark feature or the typical feature of the herpes zoster ophthalmicus, right? Then we have critical involvement of first the frontal division, then we have involvement of lacrimal division, and then is the involvement of nasociliary division. This is the stage wise pattern. So first it is involving the frontal division, then lacrimal, and then nasociliary. According to this, we have got a rule which is called as the Hutchison rule. So it is not the Hutchison Triad here, it is the Hutchison rule that is followed, that if the tip of the or the side of the nose is involved, then the chances of ocular involvement are very, very high, because first is the frontal division involved, then is the lacrimal, and then the nasociliary division, right? So we can easily rule out the other options, the Neisseria gonorrhoeae, Mycobacterium tuberculosis, as well as herpes zoster virus. Okay. Now coming to the question number 5, there is a young patient with a sudden painless loss of vision with the systolic murmur, and the fundus examination is also been shown. Now, if you remember, as I always say, sudden painless loss of vision, always think about the posterior segment, and one more thing that they have given is the fundus. So, obviously, fundus finding will be present in cases of the posterior segment. We have a systolic murmur also, and look at the typical fundus. I think N times I have revised the fundus images at every platform, and you know that what is this. So this is the typical, what is called as the cherry red spot, right? So a young patient who is coming with the sudden painless loss of vision, and there is a cherry red spot in the fundus. So what is the most likely diagnosis? The options are central retinal arteriolar occlusion, central retinal venous occlusion, diabetes, and branch retinal venous occlusion. So the most important thing where you get here the cherry red spot is your central retinal arteriolar occlusion. So let's talk about the CRAO. See, CRAO is a very important thing, and as I always say that cherry red spot is usually asked in many of the examinations. What is actually central retinal arteriolar occlusion? See, when we have the main blood supply occluded there, so we have got what you called as pale retina. So retina becomes pale, and we have lot of exudates also, and these exudates are found in the ganglionic cell layer of the retina, but there are certain areas where you do not have this ganglionic cell layer. So if I talk about the fovea centralis, so in the area of the fovea centralis, the ganglionic cell layer is absent. Because this layer is absent here, therefore we will not have the exudates here, we will not have the collection of the exudates, rather choroid continues to shine, choroid continues to shine from this place. So choroid is continuing to shine, we do not have any exudation here, and that is the reason why we have the cherry red spot. A very very important thing, that the cherry red spot is not due to any blood or any pigment, rather it is the only normal area that continues to shine through the fovea centralis, because you do not have the ganglionic cell here. Now another important thing is that what is actually the DD of the cherry red spot. Very very important, because many a times we get this question on cherry red spot. So what are the things that we can think of? So a very very important thing is that always remember, it is the cherry trees. Cherry trees never grows tall in the mud and sand. Cherry trees never grows tall in the mud and sand. We have got CRAO, T for Tay Sachs disease. Then we have got Niemann Pick disease. Then we have got the gangliosidosis and the Gaucher's disease. Then we have got T for trauma is there. Now always remember, what kind of trauma is this? This is actually the trauma which is the blunt trauma, and whenever we have blunt trauma, we can have the macular edema. Macular edema, and this macular edema is called as, this is again an important question, this is called as the Berlin's edema. This is called as the Berlin's edema, and therefore Berlin's edema will also show you the cherry red spot. Then you have got mud. This is your metachromatic leukodystrophy. Metachromatic leukodystrophy. We also have the Sandhoff disease. Right? So there are so many causes where you get the cherry red spot, but one thing more that you need to know, that though we have this cherry red spot in cases of Gaucher's disease also, but this is not a true, it is a pseudo cherry red spot. So while you are picking up, you should know that which one to choose and which one to rule out. This is a pseudo cherry red spot. Now another important thing that you get in cases of CRO, see look here, if I am concentrating on this very question where we have a CRO, central retinal arteriolar occlusion. So what is happening? I told you that you will have the pale retina, you will have edema, and at the place of fovea you will have that cherry red spot. Another important thing is that there is also the segmentation of blood column. There is also a segmentation of the blood column. So due to the central retinal arteriolar occlusion, we also have the segmentation of blood column, that is typically called as the cattle track appearance. Can you see this? This is also, is it visible guys? So this you can see, I'll make it red one for you. You can see this one small, this is called as the cattle track appearance. This is the segmentation of blood column that is found due to the central retinal arteriolar occlusion. So C for CRO, C for cherry red spot, and C for cattle track appearance. 3 are the very very important things. Alright.